Okay, good morning, good morning. Glad to hear all the conversation, and there's going to be a lot of conversation today. I'm Jean Witowski-Wendy. I currently am the Dean of the School of Public Health and Health Professions, and just want to welcome everyone here. We've got a wonderful agenda, a very packed agenda, and I'm just happy that we could do this. We have been having Global Health Days for years. I want to recognize our Director of Global Health, Dr. Lena Mu, who helped to organize this with Jen Foster, and I don't know where Jen is in the back. So they've got both entrances and exits covered here today. So we're going to be learning about food, nutrition, and health in the U.S. and around the world. And we have a great keynote speaker, Dr. Marian Neuhouser. And Lena will be doing the introduction, but I just want to personally welcome her. She has been a wonderful colleague in the Women's Health Initiative. She is in Seattle at the Fred Hutch, and we've been working together for 30 years. So it's just such an honor and pleasure to have her here in Buffalo. Her expertise is obviously on nutrition and health promotion, and she does work from interventional studies all the way to population health, and I think she's going to give us a great talk. We have a number of speakers today. The agenda lists everybody's topic, but talks are going to be on diet and chronic conditions, nutrition and smoking, cessation, how diet can impact cancer prognosis, access to healthy foods in underserved populations. So there's a bit of everything here, and I think we'll all learn a lot. So I want to bring up Dr. Lena Mu, who's Associate Professor in the Department of Epidemiology and Environmental Health. As I noted earlier, she's the Director of our Office of Global Health Initiatives, and she will tell you a little bit more about the event and also introduce Dr. Neuhouser.
Thank you very much, Jean, and good morning, everyone. Welcome to the Global Health Day Symposium. We're very fortunate to today have our keynote speaker, Dr. Marian Neuhouser, and a few colleagues from UB together to discuss such an important topic, as our Dean Witowski-Wendy noted. We're also very delighted today have a few of our graduate students going to present their work around the nutrition topic too. I hope you all will enjoy the talk and also the discussion afterwards. Now I would like to introduce our keynote speaker, Dr. Marian Neuhouser. And Dr. Neuhouser is a professor and program head in the Cancer Prevention Program, Division of Public Health Science at Fred Hutch Cancer Center. She's also the core faculty in nutritional science and affiliated professor of epidemiology, School of Public Health, and University of Washington. Dr. Neuhouser completed her undergraduate degree in community nutrition at University of California, Davis, and her PhD in nutritional science at University of Washington, followed by her postdoc training at the Fred Hutch Cancer Center, where she subsequently became the faculty and spent 28 years engaged in cancer-related nutrition research there. Dr. Neuhouser has been principal investigator and co-investigator of numerous NIH and USDA-funded grants focused on dietary modification intervention for reduction of cancer risk and progression of existing disease, the short-term intervention trials to delineate the role of food, the food composition, and dietary pattern on human metabolism and physiology. And for dietary biomarker discovery, we'll hear a lot about this today. And also methodological research to improve dietary assessment used in cancer prevention research. Her research design ranges from large observational cohort to controlled feeding trials. She has authored over 450 peer-reviewed manuscripts in the biomedical literature. Dr. Neuhouser is a member and the chair of the NIH Lifestyle and Health Behaviors Scientific Review Group and a member of the Food and Nutrition Board of National Academy of Sciences and Engineering and Medicine. Dr. Neuhouser was a member of 2015 Dietary Guideline Advisory Committee and was the president of American Society for Nutrition 2016 to 2017. And she was elected as a fellow of the American Society for Nutrition in 2023. Congratulations. And is a deputy editor for the Journal of the Nutrition. As Jim mentioned, many of us here, our colleagues, including myself, had the opportunity to work and collaborate with Dr. Neuhouser through Women's Health Initiative and through various projects. Really honored to have her here today. And the title of her talk today is Advancing the Human Health Through Nutrition, a core foundation for health promotion and disease prevention. Please join me in welcoming Dr. Neuhouser. Thank you.
Okay, great. Okay, is that good? Is it on?
Just hold the on button.
Okay, is that good?
Okay, try now.
Okay, how's that? Better?
Yeah, move it up just a little bit. Okay.
Better? Well, thank you for this invitation to be here today. It really is my great honor. And thank you, Jean and Lena, for that introduction. So here are my disclosures. So when Lena first invited me to be part of this symposium, I asked her, I said, do you really want me? Because most of my current research is not focused on global health. But I do want to let you know that I haven't always been a nutritional epidemiologist focused on cancer and other age-related diseases. And that my original career goals actually did focus on international nutrition. So I thought I'd tell you a little bit about that before I get into my current research. So when I graduated from undergraduate at UC Davis, I lived for 3 years in Recife, Brazil, which you can see on this map. It's in the northeast part of the country, and I was there for 3 years. At the time, Recife had about 3.5 to 4 million people in the metropolitan area. Nearly half of the people lived in poverty, and about 2 million, or nearly half of the population, lived in favelas or squatter settlements. It was a big metropolitan area, but a lot of people living in poverty. In fact, at the time, this was in the early 1980s, it had the 4th worst living conditions in the world. Every favela had a name. Where my husband and I lived was called Favela Caranguejo, and Caranguejo means crab. And this was a river that went out to the sea. That the tide came in and out a couple times a day. And so when the tide was low, little crabs would come up and people would catch them and eat them. These little blue crabs. So that's why it was called Favela Caranguejo. So this was our house. This is the back of the house. You can see one of the neighbor kids, running in front. So we lived and worked in the community that we were engaged with. There were always lots of kids around. It was very common for older kids to be caring for the younger kids, as you can see here in the picture. But they were always smiling, very happy. And then you can see in the background a grandma also caring for a kid while the parents worked. This was our neighbor across the road. Her name was Maria Jose. She had 3 living children. Her first 7 children died after they were born, from malnutrition. And most children in the favela were malnourished and stunted. So these 3 children were about 2 years behind in what their height should be, for their age. And that was very common. Most children were stunted. At the time, in the 1980s, Northeast Brazil had a very high infant mortality rate. So again, you can, see the Northeast up here, more than 160 per 1,000. So this was a really high infant mortality rate, more than 160 per 1,000 live births. And reasons were related to social determinants of health, poverty, structural inequalities, nutrition was a big factor, and especially infant feeding practices. That was a big cause of this high infant mortality rate. Very few women breastfed at the time, so breastfeeding promotion was a really good way to intervene with nutrition and improve overall health. So this is another one of our neighbors, Carmenia, and she was one of the few who breastfed all her children. And so they were all healthy. You can see this little guy here, Mateus. He was quite round and plump and very healthy, never sick. And this one, João Paulo, he was named after the Pope when the Pope came through. There were lots of babies named João Paulo at the time, John Paul. So he was also very healthy. They were all healthy and normal sized. She didn't bottle feed at all. So she teamed up with me to increase breastfeeding in the community. We had a lot of, moms classes where, pregnant moms would come. We would do a lot of home visits, especially when it was, close to the time of, giving birth. And then the follow-up was also, really important to increase breastfeeding in these women so that their children would live and be healthy. This woman is named Gracinha. Right here. She was also living in the community, and her first 4 children were all stunted and had poor health. So the 4-year-old was the size of a 2-year-old, the 6-year-old was the size of a 4-year-old, and so on. And she had never breastfed any of her babies because she was told by her doctors, oh, your milk is too salty, you need to formula feed. They send them home with the formula packs from the maternity hospital, and then it's very hard to reestablish, the milk supply. So I worked with her through her pregnancy, and she said, well, maybe I'll try it. Maybe I'll try it. And then when she came home, that first day, from the maternity home, I was at her house, constantly, and I didn't have any children at the time. So Carmenia and some of the other women really did help me so that they could be an example too. And the reason she had a big smile on her face is that this baby was healthy. It was never sick. And she actually said to me one day, I didn't know it was possible to have a healthy baby. She thought that that's just the way life was. If you lived in a favela, your babies were unhealthy, they were always sick, and they were small and stunted. So this is just one example of many, but soon after we came back to the States, she and her family moved down to Sao Paulo. So when we've gone back to visit, she hasn't been there. I haven't been able to check up on her, but I'm hoping that, I'm hoping that this little girl had a good start in life and that she remained healthy, for the rest of her life. So, I really did think that this was going to be, how I was going to spend a lot of my research career. And as I said to some of the trainees yesterday, sometimes your career and your research takes different paths, and it doesn't always have to be linear. Nonetheless, these women and their families continue to inspire me. I always think about them. This woman right here, this was one time a visit when we went back. Her name is Mita. She didn't know how to read or write, but because she didn't have schooling, she was too poor, but boy, was she a powerful, strong woman. She organized the community to go downtown and ask for water rights for the community. I'd never been part of something like that before. And when she asked me one day, do you want to come with us? I said, sure. And I was just amazed at the force and the power of this woman to speak eloquently and clearly in front of these, government officials to get water, a very basic right. And they got water. It was really amazing. So they continue to inspire me, and they've motivated for me a lifelong dedication to understanding the importance of nutrition across the lifespan. So now we're going to fast forward to the 21st century, and I actually do research at the other end of the life course at this point in older men and in older women. So started out in the early life course, now I do things in the later life course, but I am a very strong believer that nutrition is a core foundation for health promotion and disease prevention, even in in older adults. It's never too late to start and maintain good nutrition habits. So the 3 leading causes of death in the U.S. are nutrition related. So you can see on this graph here that heart disease, cancer, stroke, and diabetes, those are all leading causes of death, and they're all nutrition related. It's not the only cause, but we can prevent some fraction of cancer, stroke, heart disease with good nutrition and also healthy weight. So one of the areas that I have been working in is prostate cancer. So prostate cancer is the most commonly diagnosed cancer in men, and it's the second leading cause of cancer mortality in men in the U.S. And you can see here that there really was a spike in diagnoses in the early 1990s. This mirrored the rise in PSA screening in men. So that's why there's a big spike, and then it's come down. But it still remains the most commonly diagnosed cancer in men. And cancer risk is affected by energy imbalance. So this is where some tie-ins come with nutrition and obesity and my interests there. So on the top is the population attributable fraction of cancer risk in men, and for women it's on the bottom. So the darker the color, the stronger the population attributable risk between obesity and cancer. So a pretty strong relationship for many cancers, and especially for cancer mortality. So I've been working with urologists in a team science situation for many years on active surveillance of prostate cancer. So about half of all prostate cancer diagnoses are low risk. They're managed with active surveillance, and that's the current standard of care to monitor patients who have this kind of low-risk prostate cancer. Men come in about every 6 months to get their PSA checked. Often they'll have a routine biopsy once or twice a year to see if the pathology has changed, and then there'll be imaging as well. So the idea is don't intervene and do definitive treatment if you can keep men in this low-risk category. However, about half of men who are on active surveillance do have to go on to have definitive treatment, which is usually treated by a prostatectomy, often radiation, and sometimes androgen deprivation therapy requires that as well. So this urologist and I, who's a tremendous partner, we've been working on this idea that, can we prevent disease progression? Can you just live with low-grade, prostate cancer and not have it progress? Is that even possible? So it's well known that weight gain after diagnosis of higher risk prostate cancer is increased with risk of recurrence of poor outcomes after a prostatectomy. Less is known about active surveillance patients, but this is one study that did show that men who were obese, sorry about the typo there, the obese is the green line, that they had greater probability of progression than men who were normal weight, and these were active surveillance patients. So one reason might be due to the glucose regulation, and this is showing here some differences in the insulin receptor, the IGF receptor, and the phosphorylated insulin receptor and IGF-1 receptor in men who have progressed. So, some studies have shown that glucose dysregulation may be some of the fuel that pushes men towards moving from low grade to a higher grade prostate cancer. However, it's really hard to change lifestyle habits. I wouldn't say especially when someone is in a more advanced stage of life, but it is hard to change, habits. And so this study showed that, men who were on active surveillance, it's really hard to just lose weight on your own and change your health habits. You do need some, guidance or instruction. Some people might say, well, it's a teachable moment. If someone's diagnosed, men are really going to want to lose weight on their own, start exercising, lose weight and so on. It's very hard to do. And so this study, that I was involved with, that you kind of monitored men on active surveillance that weren't getting any intervention. It was only a very small fraction actually did so on their own. So Jonathan Wright has been the PI of the study. He's the urologist I work with. We wrote a grant called the Prostate Active Lifestyle Study, or the PAL study. And we designed this study so that we would try to recruit men when it was close to 6 months after their diagnostic biopsy. Because if they were going to get an annual biopsy, we wanted them to be on our 6-month intervention. So at the end of the intervention would be right before their next biopsy. So it was kind of a slick design so that we could get those tissue measures, which is kind of unusual in most population type studies. So we recruited 100 men with low-grade prostate cancer, but they had to have a BMI of greater than 25. And then we redesigned the diabetes prevention program curriculum, and we did an individual intervention. This was not a group intervention, so we had a dietitian and exercise physiologist who were delivering the intervention. We provided both nutrition, guidance, as well as physical activity. And the goal was that the men would lose 7% of their baseline weight, which was similar to the diabetes prevention program, where the goal was 7% weight loss. And our primary outcomes were biomarkers in the obesity insulinemic pathway to see if that could be the pathway or the mechanism to prevent progression. So one question that we got asked when we first submitted this to the NIH was, is weight loss through nutrition, physical activity in older men feasible? Because our mean age was about 65, and we accepted men up through age, 78 or 79. We definitely had some skeptics. So these are some actual, comments from our first summary statement. One person said, not sure this can be done in older men. Someone else said, everyone knows men can't lose weight and won't change their diet. And then another reviewer said, in-person visits for elderly men are too much. So we did have some skeptics, but we did get funded, and this is our beautiful prevention center. This is the exercise facility where we have an exercise physiologist delivering the exercise portion of the intervention. In reality, it was a great success. We did have elderly men come in, do the intervention, and they did great. We gave them, in addition to the supervised intervention that was taken from the diabetes prevention program, they were given drop-in sessions to our exercise research lab. And men did take advantage of those drop-in sessions. They could come and use the exercise equipment whenever they wanted to. And then they would report back to their community urologist, because the beauty of partnering with a urologist is that he had connections with all the other, urologists in the area. So that not only helped us with recruitment, but then Dr. Wright could report back to the physicians on how, the men were doing. And they would often report to their urologist when they would go in for their every 6-month checkups, this study changed my life. So we kind of blew the skeptics out of the water, and it really did work for these older men. So what did we learn? In the intervention arm, men moved from being in the obese category. They moved down to having a mean BMI that was in the overweight group. So that's not that easy to do, to move from having a BMI of over 30 to moving into a BMI, on average of 26 to 27, in about 6 months. So they really did a great job, and have to, thank staff for being so great at doing this. You can see adiponectin here. We like to see an increase in adiponectin because that's thought to be a beneficial hormone, and that increased more for men in the intervention, and men on the control, it decreased and then kind of flattened out a little bit. C-peptide also went down. It increased decreased the most at 3 months, and then kind of, flattened out, and then fasting glucose also did flatten out. So we view this really as a success, that men move from being obese to overweight. They improve biomarkers of health. We took their vital signs at each time, and their blood pressure also decreased, and improved their overall health because we did some measures of, quality of life and so on. We do have several next steps for this study in older men. One is we are currently analyzing our body composition data because we had DEXAs done in our prevention center, both at the beginning and at the end of the intervention. And I can't reveal the data now because we are still working on it, but the body composition data look, very interesting and very promising. So we're excited about that. Mostly because in older men, you worry a little bit about doing weight loss if you're going to have a lot of lean tissue loss. And I think we're seeing some positive results, partly because we did have, exercise with this. It wasn't just weight loss, but we did have weight training and resistance training. And then we're also currently getting all the tissue from the various sites where they've had their biopsies, but we really want to measure. We have all the pre-study biopsies, so now we're getting the post-study biopsies, and then we're going to do some IGF staining, on those tissue specimens, and that will really tell us, okay, is there a chance that this weight loss and this improvement in biomarkers could, slow the progression? What does it look like in the tissue? So we're excited about that. So stay tuned for that. So what about in free-living people? This was an intervention, a pretty intense intervention because it was a one-on-one delivery. It wasn't a group-based intervention. It was in person. We even worked through the pandemic. We had, amazing staff who cleaned all the equipment really well. The men were willing to take COVID tests, the day before coming in. So that was a lot to have to ask them to take a COVID test the day before coming in, and then, come to their exercise or nutrition session. So we were able to, work through that. We did do exercise tests to monitor their exercise capacity and VO2 max tests. And there were a few men who decided they didn't want to do the VO2 max test, even though all of the equipment was sterilized, because they felt uncomfortable with having something in their mouth that maybe someone else had used and breathed through. But that was only a small number of people, and we are analyzing that too. So it was a very intensive study in terms of staff, intensive for the study participants. So what can we learn about nutrition as a core foundation for health promotion and disease prevention in older adults in the observational setting? And in many ways, this is more difficult because dietary assessment is really challenging to try to find out what people are eating. In my view, after doing this kind of work for more than 30 years, diet is one of the most complex exposures to assess. We have lots of things, in food. We have 3 macronutrients that give us energy: protein, carbohydrate, and fat. Plus we get calories from alcohol. We have micronutrients, which are vitamins and minerals. Fiber, which is not technically a nutrient, but needed for health. We have phytochemicals. These are things in plants that are not nutrients, but they're health promoting. Things like carotenoids, polyphenols, isoflavones. And food also contains contaminants, pesticides, herbicides, nitrosamines that get formed in cooking. We have pathogens. The food feeds the microbiome, and the food interacts with the metabolome. So it's really complex. In part, that's what makes it really interesting and challenging. We always have work to do. Diet is also multidimensional, so this adds to the complexity because we can measure nutrients, we can measure constituents, compounds that we think have some biological effect, but they're not technically required for human nutrition, so they can't be called nutrients. We have single foods like blueberries, green tea, garlic, we talked about yesterday. We have foods as eaten, like pizza, tacos, sandwiches. We have food groups, fruits, vegetables, so on. And then we have other attributes such as the pesticides, toxins, and pathogens. So what are you going to measure? You're going to measure all of those. It gets pretty complicated. It's multidimensional. Diet is also a behavior. So it's taste, enjoyment, family and friends, health of the planet, availability and familiarity, because you can only eat what you can afford to buy and what is available for you. It's culture, it's celebrations and holidays. It's a marker of health equity, food insecurity, and it's also stress and emotions. So again, diet gets very complicated because it's things that we need to function, but it's also a behavior and an economic parameter. Common dietary assessment, as you all know, is from Self-Report. Here on the left, we have a food frequency questionnaire. This is an updated version of the one that we used in the Women's Health Initiative, where people have to mark, if they ever eat these foods, how often, what the serving size is. So we give an example of what a medium serving size is, and they have to think in their mind, okay, is that about what I eat? Do I eat more than that? Do I eat less than that? So these things get really complicated. And then you can see, I don't know if you might not see this in the back, but this line here asks about bread, but it's with other things, wheat bread, including bagels, rolls, and English muffins. So that grouping might make someone think of breakfast. So if they don't eat wheat bread for breakfast, are they going to mark that? Would they really be able to think, okay, if I ate a sandwich, 3 times a week, oops, sorry about that. Should I put down the wheat bread? So people have to kind of deconstruct what they eat. And that's not an easy thing to do for anybody. It's very challenging to have to kind of deconstruct and see the foods that you eat in these, line items. We also do food records, where we ask people to actually write down, what they eat, where they ate at the time, and then the amount. We tend to think that these are more gold standard, but we also find that there's a lot of foods that are not included. Sometimes people add phantom foods. So it's in some ways it's thought to be a little bit more thorough when people actually write down what they eat, but the jury is a little bit out on that. And then we have some questionnaires. This is a mindful eating questionnaire. They ask about behavior. So there's lots of food behavior types of questions. Some other complexities of food is meal timing, meal frequency, special occasion foods or everyday foods. There's a notion called episodically consumed foods, and one item you can think about is fish. Fish for many groups is considered an episodically consumed food because it's not something that people eat every day or even every week. They might have it a couple times a month, if that much, even though the current dietary guidelines recommend more frequent consumption, because not all areas of the U.S. or other places have access to fish or have it in a way that is appealing to people. Are those omega-3 fatty acids in that episodically consumed food important? Probably yes, because they have a long half-life in the body, but it might not be captured if you're just asking, in a 4-day food record, what did you eat in the last, week? Write down every other day. Or in a recall, what did you eat the day before? You might miss some of these episodically consumed foods. Our food supply is very complicated. We have thousands of food components and food combinations. Whether someone has religious or cultural food habits that are actually captured on some of these questionnaires, I think we need to understand that a little bit better. And then people have perceptions about what's healthy and not healthy. Even if the perceptions are not evidence-based, their reporting may be reflected in that. So many of these features of what people eat are not captured in standard dietary self-report. And so the result is that a lot of dietary data are often very noisy and include measurement error. So we have done a lot of work, probably over the last more than 20 years, about what can we do to improve our assessment of diet, and are there biological measures of diet that we can use that could be more informative? And while biological measures from blood, urine, and the microbiome might not tell us about eating behaviors, they could give us an integrated measure of food and nutrient exposure that doesn't rely on participant memory and doesn't rely on people having to deconstruct, what they eat and figure out what it is and completely fill in the food frequency questionnaire. So a lot of this work has been embedded within the Women's Health Initiative, and I know you're all familiar with WHI, this large study of women's health that started back in 1993 and still goes on today. So we've had an ancillary study, a set of ancillary studies that's been going on for many years now. We started out with one called the Nutritional Biomarker Study, and that took place when the clinics were still up and running. We did that in 12 clinics in the dietary modification trial. Then we recruited 9 clinics to be in what we call the Nutrition Physical Activity Assessment Study. That still goes on today. We did that original data collection in 9 WHI clinics, and then we did a feeding study just in Seattle for feasibility reasons. So overall, we have these biomarkers and data on over 1,000 WHI women, and I'm very grateful for the time that these women put into the study, because it was actually fairly intensive. We had to do a telephone screening to figure out if they were eligible and interested. Then they would come into one of the centers, and this first visit, they had to stay in the clinic for about 6 to 7 hours. So it was a long day. And part of that is because these first studies, we did a double-labeled water protocol, and double-labeled water is a procedure that is used to understand someone's total energy expenditure, and in weight-stable people, total energy expenditure is approximately equivalent to total energy intake. So we really wanted to get like a biomarker of energy intake. So we did the double-labeled water protocol. They also completed a number of self-reported assessments, including another WHI food frequency questionnaire, and we gave them instructions for 24-hour urine collection, which they did at home. The double-labeled water protocol actually takes place over 2 weeks, so they had to come back 2 weeks later for this visit. Probably lasted about 3 hours, where they had to bring their 24-hour urine that they collected the day before. They did a food record at home. We did another fasting blood draw, and then they have to do 2 more spot urine collections, and we did indirect calorimetry on them. And then we asked 20% of them to come back 6 months later, and they did. So that was pretty amazing for these older women, to do this. Very grateful for them. And you can see some of the biomarkers that we have right now. Of course, we have the double-labeled water, urinary nitrogen, sodium, potassium, urinary sugars, we're doing a lot of work with the metabolomics now, which I'll describe in a few minutes. And then from the blood, we have vitamins, carotenoids, phospholipid fatty acids, stable isotopes on a subset, and again, metabolomics. So this was some of our first evidence that, maybe the biomarkers were really important to consider. And this was using the W-labeled water from some of these first participants from the dietary modification trial. So this was from 543 participants in the dietary modification trial. As you saw from the last slide, we asked them all to complete a new FFQ and comparing the intervention to the comparison arm. And this is when the dietary modification trial was still going on. It was the last year of the trial. From self-report, the women on the intervention group, on average, they were reported that they were consuming just under 1,400 calories a day. But the W-labeled water told us that they were consuming on average over 2,000. So that's a pretty big difference in calories. So that told us that there was a lot of underreporting. The women in the comparison arm also underreported. We don't really know why they underreported less, but it tells us that there was probably some kind of bias because they were in this dietary modification trial. Maybe they underreported some of the foods that have a little bit more calories. So that was kind of our first foray into this. And so because, I can't describe the hundreds of papers that we've done using these data, I'm just going to give one example of a research question that we have worked with over the last several years using some of these data that hopefully will have some application to people's health. So the question is, are red and processed meats helpful or harmful for age-related chronic diseases? In 2015, IARC, which is the International Agency for Research on Cancer, declared that red meat is probably carcinogenic and that processed meat is a carcinogen. And so why? There is some biological evidence for this, mostly from preclinical animal models and other experimental models, but there's a number of compounds that are thought to be ingested at the same time as red and processed meat that may have some cancer-causing abilities. Despite some of this evidence, the links between red and processed meat remain controversial. There was a series of papers published in a well-known journal I believe these were published in either 2017 or 2018. They were a series of systematic reviews and meta-analyses on red and processed meat and all kinds of health outcomes. And they mostly came to the conclusion through these studies that red and processed meat was not harmful, and they even misinterpreted the Women's Health Initiative. Completely misinterpreted. There were hundreds of us that wrote, letters to the editor asking for some of these papers to be retracted. I was especially quite angry about them completely misinterpreting WHI data because we didn't have any goals in the dietary intervention trial specifically for red and processed meat, and in one of these papers they kind of blew that up and said, oh yes, well they didn't decrease, or women decreased their red and processed meat intake, but didn't have any effect on cancer. But that wasn't part of the intervention. The papers were not retracted, but it kind of fueled us and others to think about this. This is some self-reported data from the Black Women's Health Study. And you can see that for total red meat servings per week, the hazard ratio for rectal cancer is about doubled for consuming more versus less. Total red meat, and then for unprocessed meat, it was also more than doubled. And then this was a meta-analysis, again, relying on self-report, where some of these hazard ratios are crossing the null value, but some do show an increased risk. And then this one as well. Some of them are fairly null, but again, this was from self-report. So we have wondered how can we use some of our biomarkers to better understand this study, and this was done within the Women's Health Initiative, and this paper was led by Dr. Cheng Zhang. So what we did is we took our metabolomics that we have measured in all of these participants, and these are the metabolites that we would kind of think of as discovery, and we also allow some other participant characteristics to come in. So for example, we do have BMI in here, and we do have the baseline FFQ in here to help reduce some of the variation. And we always do a leave one out cross-validation. And then we identify the sets of biomarkers based on the cross-validated R-squared. And we like to have a cross-validated R-squared for biomarker discovery of at least 36%. And so, and that's a correlation of about 0.6. And the reason that we do that is that that's about the correlation that you would get with W-labeled water. And W-labeled water is the top biomarker gold standard. And so we want any biomarker that we discover to be as good as or better than W-labeled water. Now you can see here that it's a set of biomarkers. There's not going to be one biomarker that reflects, meat or blueberries or any of these other things. It's a set of biomarkers. So with these biomarkers, we did meet our criteria of being over 36%. And then this is for red and processed meat, same thing. It got over 36%. It was 45% for the cross-validated R-squared. We view that as very good. So then what we do, we have these set of biomarkers, and the way that we try to improve upon the self-report is that we make these calibration equations, and I could only do this work because we have these amazing biostatisticians. So this really is team science work within the Women's Health Initiative. And what the calibration equations do is they create a predicted value for red and processed meat that is used in the Cox models. And this predicted value, because we can't measure the biomarkers on everyone, is too expensive. So we measure it on a subset, and then they do this incredible, work to create these predicted values for everyone, because we know there's some variation based on someone's BMI, their age, some other personal characteristics. But then everyone does have a predicted value. So it's the predicted value that's the biomarker that becomes the exposure, not the self-report. And so we have two columns here with a biomarker calibration and without. So without biomarker calibration, this is just using the FFQ, the baseline FFQ, and what's the relationship of red meat and red and processed meat intake with these cancer outcomes. You would come away thinking, well, there's only a little bit of an increased risk with obesity-related cancers, a little bit with colon cancer, but pretty nominal hazard ratios, just a little bit above 1. But when we use the predicted values, these biomarkers, and this again is in the Women's Health Initiative Women, then we see that for both red meat and red and processed meat, then the hazard ratios tend to, come up a bit. And these would be more in line with what the IARC, declared that red and processed meat are carcinogen, especially for things like colon cancer, obesity-related cancers like endometrial cancer. So we hope that results like this can be used to, improve the health of older people by, So I really want to acknowledge and thank all of my collaborators. This really is team science. You can't do this without lots of people with different expertise, and also, the funding agencies. I'm always very grateful to the Women's Health Initiative for what an amazing cohort it is, and to the amazing women. And I want to thank you. Hope you all come to Seattle sometime.
Thank you.